Gwen's first question is, we have an unusual ACO structure in which we set up new regional practices with new TINs in which we are enrolling participating providers. All ACO patients and only ACO patients will be seen in or by these TIN/MPIs. So 2 questions. How will this structure affect measurement requirements, and how will it affect attribution?
Gwen, that's an interesting application of the model and should help bring some ease and clarity to your project. It makes a lot of sense, and I can see how this qualifies as a distinct business and warrants a distinct TIN and business structure. However, Medicare could consider it to be a loophole, and you may see that loophole closed at some point. Regarding attribution, it won't have much effect. All of your ACO TIN patients will be with the ACO, but not all ACO TIN patients will be attributed to the ACO. It will work a little differently with prospective than with retrospective attribution. In prospective attribution, most of your ACO TIN patients will be attributed to the ACO because the differentiating factor is choice. Patients choose to be in the ACO, and it's not affected much by engagement or comprehensive or comparative visit volumes. There's still some dynamics that patients may withdraw from the ACO, but will still be engaged with a practice and not attributed. With retrospective attribution, plurality of care is the deciding factor. All patients of the ACO practice are eligible to be attributed, but only those getting more primary care from your ACO TIN practice than other practices can be attributed. So more patients will be in the practice than patients are attributed. Regarding quality measurement, because only patients of your ACO will be served by the ACO TINs and NPIs, well, with it, except for those exceptions I listed prior, you will effectively avoid some of the difficulties usually encountered in all patient, all payer quality reporting. It's still a very different experience from web interface reporting. In the web interface, the patients you report on are drawn randomly from the patients attributed and only the patients attributed to your ACO. For the new APP reporting using ECQMs or MIPS EQMs, all patients, attributed or not, need to be included in the denominator, and the numerator status has to be known and reported for at least 70% of them. Great question, Gwen. Thanks.